Hello, everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Preemie Chat is one of many initiatives we have to bring information for NICU families and healthcare professionals. And today we are doing a year in review of COVID-19. Today's session is a collaboration with the International Family Integrated Care Committee, sponsored by AbbVie. Well, it's been a year since the World Health Organization declared a pandemic. Nobody imagined that the COVID-19 pandemic would be the center of our lives for such a long time. And the light at the end of the tunnel is still too dim to let us see when all this is going to end. The numbers are still staggering. The pandemic has changed every aspect of our lives, the way we work, the way we shop, how we entertain ourselves, the way we connect with our friends and families. It heavily affected the economy, the health system, our children's education, and everyone's mental health. For the families of preterm babies, it has been an extra layer of stress. Since the beginning of the pandemic, restrictions were put in place in ICUs around the world. Parents became visitors. The stories that are coming to CPBF are heartbreaking. Research has shown the short-term impact, and we can only predict the long-term impact on babies' development and parental mental health. And we have 3 sessions today with 3 different guests from different parts of the world. And we're going to start right here with Dr. Aniko Dyer, followed by Karen Lasby from Calgary, and Dr. Faith Su and Dr. Prakash Shah to end the session today. So joining me from London, England, is Dr. Aniko Dyer, talking about the impact of the COVID pandemic on neonatal services in UK. This talk will include how maternity and neonatal services were affected by the pandemic in UK, particularly through Dr. Dyer's experience at the Imperial College Healthcare NHS Trust in London. In a unit with strong ethos of family integrated care, it was stressful to overcome hospital regulations, including limited parental access, inability to deliver face-to-face family support or educational activities, and trying to reduce the potential damage with innovative alternative options. Dr. Dyer is a consultant neonatologist at the Imperial College NHS Healthcare Trust in UK. She completed her training in Paediatrics and Neonatology at Semmelweis University in Budapest and continued her work in London. She was awarded a PhD in neuroprotection in 2012. Since then, she diverted her interest towards equality improvement methods. She implemented an integrated family-delivered neonatal care model. She was responsible for the COVID-19 neonatal pathway at the Imperial College NHS Healthcare Trust during the first and second waves of the pandemic. Dr. Dyer, thank you so much for joining us on this Friday evening for you in London. I'm so grateful that you are joining us and sharing your knowledge and expertise.
It's really my pleasure, Fabian, and thank you for the invitation to take a part in this series, because it's important that we reflect on the past year and we reflect what have we done well and what can we do better in the future, as the end of the pandemic is not near yet. Can you see my slides, Fabiana? And
yes, I'm going to add your slide to the broadcast, and I know we're going to go through your presentation, but we are having a period of Q&A at the end, so feel free to send your questions and comments on the box below, and I'm going to address them at the end of the presentation. Okay, you have.
All right, so I'm going to talk a little bit about the impact of the COVID pandemic on the neonatal services in the UK, and I will touch base how also our maternity services and children's services were affected. It's quite a lot to include. I'm conscious about time, but I think it's important to reflect. And just to put everything into context, this is a brief timeline how the UK was affected by the pandemic. We had 2 very strict lockdowns, and the second is still ongoing, hope to be lifted in the next few months. And as you can see, up to date, more than 4 million people tested positive with coronavirus, which resulted a first and a second wave. And I think now we know that the second wave was a lot more challenging. You can see the peak where the UK B1117 variant became dominant. and we faced more hospitalization in the NHS hospitals. And this resulted more than 100,000 deaths in the UK, which are kind of attributed to COVID-19. And we know there was more significant damage, collateral damage, and you can see here the excess mortality in the UK over the past year. There is light at the end of the tunnel. You know, one thing which is going well in the UK is the vaccination. And I think by today, we're close to 25 million doses to be administered, and we are down to the age group above 55 years old to vaccinate. And first, let's start how maternity services were affected. And first, we need to talk how COVID-19 affected preterm labor and outcome of those mothers and babies undergoing COVID-19, looking at some population data, cohort study, and databases. This was an unknown and new disease, and it was an extremely rapid learning we had to do. Everybody suspected that pregnant women can be affected negatively by the COVID-19, by the SARS infection, and there were fears around adverse pregnancy outcome. There were very variable recommendations across the globe how to manage these situations. And the main questions were what effect the COVID-19 can have on pregnancy outcomes and preterm birth rate, and what kind of the transmission and the result of that and the effect on the baby. So there were interesting reports across the globe when we talk about preterm birth, and this was a Danish observation when they compared premature birth rate to previous years, and they found that there was a significant drop of the extreme premature delivery rate, while there was no significant change in the total number of live births. And you can see that it was really significant from about 1,000 births. It dropped down to 0.2 per 1,000 live birth during the nationwide lockdown period. And this was followed by the Ireland observation again, which is kind of an area where, again, they noticed that during their lockdown period, they actually have no extreme low birth weight baby delivered. So what have we seen in the UK? You can see the preterm delivery rates over the past 10 years. They are pretty static. They're around 78% overall. And you can see the extreme preterm delivery rate is about 0.5 per 1,000 live birth, not changed much over the last 10 years. And you can see that I think there was not much change in 2020 either. Maybe the overall rate of preterm birth decreased slightly, but definitely the very preterm and the extreme preterm rate remain the same. So we have not seen similar drop in the UK. And this is our NICU activity based on bed days from last year. And you can see that from April to June and kind of last winter, when we had the 2 waves of the pandemic, there was a little bit of dip in the activity, but this was not really related to a decreased number of babies born needing admission to the neonatal unit. Definitely the second wave, we may had some staffing issues which resulted on capacity issues, but we have not seen a similar drop in the UK in preterm birth. In the Danish paper, there are kind of couple of hypotheses why this could happen, and definitely lower risk of infection in pregnancy and environmental pollution can be 2 hypotheses why this can happen. And this is UK data, how similarly to Australia, we have seen that respiratory viruses were wiped out. There was no community transmission of these viruses. And there are some hypotheses that viral infection could trigger preterm birth. And again, that during the lockdown period, there was significant improvement in the air quality overall. What are the outcomes then, for mothers and babies affected by COVID? And here I would like to highlight the pan-COVID registry, which was the work of my colleague. This database was coordinated by Imperial College Healthcare NHS Trust and the college. And they basically set up very, very rapidly a pregnancy and neonatal outcome registry focusing on outcomes of the pregnancy, for example, miscarriage and pregnancy losses, how this can affect fetal growth and stillbirth rates, including preterm delivery and rate of vertical transmission. You can see that there is about 11 countries participating in the data submission, and they recently published the largest cohort of pregnant women and pregnancy outcomes in this topic. So there was over 4,000 pregnant women included either in the pan-COVID or in the American registry. And they, in fact, concluded that preterm delivery occurred in a higher proportion of women with SARS-CoV infection in both the registry. However, the majority of the preterm deliveries occurred between 32 and 37 weeks, so not in the extreme preterm category. So they also concluded that the SARS infection in pregnancy did not appear to be associated with negative effect on fetal growth or adverse neonatal outcomes or affecting the rate of stillbirth. You can see that there was a big difference in practices. So the majority of the infants in the US had neonatal screening performed, while in the UK, this was not standard practice. And the vertical transmission or overall positivity rate in infants were about 2% following a SARS infection. It was really, really great to see that neither registry reported any neonatal death, which were attributable to COVID infection. And this is just the table below. Now, let's talk a little bit about neonatal services and how we try to maintain our values in the pandemic. We at Imperial College have a very strong value and a culture of family integrated care. And it's over about 6 years that we implemented this care bundle with our multidisciplinary team. And this really become the way how we work, that the parents are part of the neonatal team. They're involved in the care as much as possible. And parents are involved in shared decision making and understand all the aspects of the care. So the hospital responded obviously restricting any presence or reducing the footprint on the neonatal unit. And again, we didn't know much about this disease. There was a main question how these preterm babies will be vulnerable to this virus while in hospital or post-discharge, especially the ones with chronic lung disease. And we had to ensure that the neonatal unit remains safe and we can provide care as business as usual for mothers and their babies. And we have put so much into this, the Zero Separation campaign, which all the organization did together. And on the lower part, you see our efforts. So we try to offer delivery room cuddles to all extreme deliveries following stabilization. We try to provide colostrum within 6 to 8 hours of life to these babies. Have the parents on board with their care, and we encourage regular and early skin-to-skin cuddle on the neonatal unit. These were all in substantial risk, by the COVID pandemic. So we were guided by the Public Health of England guidelines and also the British Association of Perinatal Medicine and Royal College of Paediatrics in the UK. And we had to outline the pathways for low, medium, and high risk mums and babies. And basically, how the baby's status was defined by the mother's status and then followed up by routine screening or their status. And, we developed pathways how actually to admit and where in our shared bed nurseries according to their risk status. And a lot of countries went down on separation, US and China. We know that they had very strict separation, limitation of breastfeeding and skin to skin with COVID positive mothers. And reports started to come out not seeing significant mortality or morbidity here. However, we were really great that kind of the UK took a more liberal approach, similar to the Scandinavian countries. We were trying to encourage no separation, allowing skin to skin and breastfeeding just as would be usual for routine care, and keeping the mother-infant diet together for well-term infants inside rooms, and not performing COVID tests for infants only if they are symptomatic or become unwell, facilitating early discharge to the community. If the infants was needing admission to the NICU, then they were admitted to high-risk isolation nurseries, and we have performed routine screening on day 3 and day 5. Clearly, we had some restrictions for parents who were either positive or had contact with a positive person. The UK had very wide practice, again, how parental access was maintained. Many units had time restrictions and one parent only, and they had to book appointments for a particular part of the day. We were very lucky that we managed to maintain unrestricted access for one parent always. But we again had a very difficult 2 to 3 months when sadly we were not able to allow fathers to the unit at the beginning of the pandemic. Having BLIS and BAPAM on board, providing a statement that the parents should not be considered as visitors was really helpful, because with this we managed to challenge the hospital board and reinstate the parental access in June 2020 and maintain unrestricted access for both parents since through the second wave. How did we try to maintain safety? So our parents will complete the symptom checklist when they come every day to the unit. We decided not to go down on the temperature measurement route, as we felt with literature review that there is no evidence that would add anything to our safety. We have not performed till this point asymptomatic screening for parents, and parents always had access to the same PPE than our staff. And this is just an example of the symptom checklist we asked the parents to complete. And I think the hospitals always had as a goal to try to ensure that no patient will get COVID-19 in a hospital and there are no outbreaks involving staff and patients. And I think we are very happy to see that till this point, there is no report in NICU settings on outbreak, including babies or patients. There is no report from patient to patient transmission. And again, there isn't really reliable reports from parent to staff transmission. And that's very reassuring and should provide evidence how we can operate NICU safely. We have to focus on staff-to-staff transmission. Definitely in our unit, this happened more probably when people were out of the clinical area, not wearing their mask. And always keep in mind the potential vertical or horizontal transmission for the individual neonate from the parents, which we clearly have seen example in our services as well. I think additional testing will provide some safety. Our mothers having universal screening for a relatively long time now, and we have access for rapid testing with an innovative method called DNA nudge. And for this, we can have a turnaround time within 90 minutes. So we have a mom who walks in at 24 weeks pregnant, who is delivering. We actually able to get a very quick result about her COVID status. And since the summer, we actually started implementing a weekly PCR testing for our neonates who are undergoing aerosol generating procedures, so any respiratory support, because in this way we can maintain their low risk status and not to have to wear advanced PPE. This was about rapid testing. So we testing staff, again, this probably has a place, and again, we have performed previously asymptomatic PCR testing, but we stopped this because the pickup rate was really, really minimal and was not felt to be beneficial. And at the present, our staff is doing twice weekly lateral flow testing, which they are performing, at home and submit their results. What challenges we face, similarly to probably other neonatal units across the globe, staff sicknesses, which was related to COVID-19. And I think we have to add the additional emotional trauma related that we all have seen colleagues hospitalized or witnessing bereavement in our very near work environment. And some colleagues were not able to return due to long COVID. It was not unfrequent that people had to self-isolate due to household contact or due to school and nursery closures during the lockdown periods. And some of us actually, however, nobody got deployed from the NICU. We volunteered and we went to do a couple of shifts at nurse buddy to PICU, or a couple of us helped with vaccination as well. For staff, there are other fears and challenges. Majority of our staff is actually vulnerable, either because they have underlying comorbidities or they're coming with a BAME background. And the physical distancing just means, and the PPE, that there is less support we can provide as we are working on the NICU. There were changing policies sometimes and changing PPE rules, which were difficult to cope with. And there was a need for continuous education to understand risk of transmission, PPE use appropriately, definition of the different risk pathways or contact status. and and this had an effect on the staff mental health. The parents were in the similar situation. Physical distancing also meant that their partners often were not able to support them at the cot side. There was separation due to COVID or COVID contact status when they were not able to see their baby for a period. Lockdown restrictions sometimes meant that families struggled with childcare and they were not able to spend as much time on the NICU as they wanted. And again, it was important that we educate our parents and they understand what this pandemic really means and how to keep each other safe. One topic what I wanted to highlight is really the skin-to-skin contact. And however, we always encourage skin-to-skin because it's a very close physical contact. In many ways, it's a close physical contact between the mom and the baby. And also the staff have to closely support this to happen. We have seen that this actually resulted some anxiety and fears. However, there is very good evidence that all the benefits skin-to-skin can provide is massively outweighed any concerns about a possible horizontal infection of the baby with COVID. Another area where we have seen that this is resulting some difficulties, helping a mom to express colostrum is a very intimate relationship. And you can see this was a QI project we started before the pandemic. And I think when the mother status is unknown and there is a pandemic and we're wearing PPE, it's a very intimate relationship to help a mother to express few hours after delivery. And we have seen massive drop down in our colostrum rates. So this graph is showing percentage of babies who receive colostrum within the first 24 hours. And both with the first and the second waves, we have seen a drop, which we are trying to work ourselves back. How can we support the parents and how can we maintain our values around family integrated care? There were 3 areas where we had to support our parents. One is to encourage not just parental presence, but long parental presence, that they have quality time at the cot side. Maintain personal connections and bonding with the family between staff and parents, because PP and physical distancing made this very, very different compared to what was the culture and values before. And again, support the family unit, because in our unit, we not always managed to have the mom, the father and the baby all together at the cot side. So we had to ensure that somehow we still bring that family together. We have our IFDC app, which was designed by our trust, which contains consistent and reliable information. And certainly this was useful through the pandemic as well, to provide information about neonatal care, and they could use this as a diary. And again, many things had to be converted to virtual. So we have a weekly MDT ward run, where again, we encourage parents to present and lead the conversation. And we had to convert this to virtual, and sometimes we had to use different channels. So we have used Microsoft Teams, FaceTime or Skype for these, and parents were booked to appointments during the ward round, and we performed the ward round that way. And similarly, our parent group, which was facilitated by a psychologist, have to move to virtual as well. We, in the family integrated care model, we have a rolling educational program for parents, which basically was small group teaching face-to-face, and this had to be limited during the COVID pandemic. So this had to be converted to something else. And our amazing therapist actually decided, rather than doing this kind of group sessions, they selected a couple of days when they were just around in the unit and mostly provide now one-to-one support to the parent who is at the cot side for individual support, which actually takes more time and more investment, but trying to support the parents in the same way. In the unit previously, we had lullaby hour and baby massage. And again, we made an attempt to make this virtual as well, which is extremely popular. We managed to do it with about 8 families, because probably that's what our occupational therapist is able to control over the screen. And you can see a screenshot of the last session here. Another small little ideas, we bought some Polaroid cameras. So if we have a COVID-19 positive mom who is separated and just delivered and on the labor ward on her own, of course we can do photos on the mobile phone, but it's just nice to have a physical picture which we can give to her hand and she can hold and watch anytime. We are using mini boos, which is again 2 little cloths, which one is always with the mom and one is always with the baby, just to make, to help the bonding with the maternal smile. And for babies who had mom in critical care, our nurses started a handwritten little diary, which is not completed every day, but maybe with some important milestones, the nurses handwritten an entry, so the parents, when they get better, have some idea, what their baby journey was like. We are also using the VCreate system, which is a secure video messaging system, which was implemented in the UK, and majority of the UK neonatal unit had access during the pandemic. So the parents had to register on this on admission, and we used this when the parents were not able to visit. You basically recorded videos, and then you were able to link that to the parents and send that to the parents' account, which was a really great opportunity. But we felt that it often have not replaced the need for live connection. So on the top of this, we often had to FaceTime the parents so they can see their baby in real time. There are 2 examples I just wanted to highlight how an organization actually can support clinicians and families. And the 2 examples, we had a clinical reference group set up at the very beginning of the pandemic for fast decision making. This is chaired by the medical director. And this was for a rapid policy approval to have a consistent approach within the organization and within specialties. And neonatology for us had a representation. So it made our access quite easy to raise, for example, parental access to the unit when we're trying to change the very, very strict restrictions. And the other thing which was a fantastic opportunity is the clinical decisions support group, which was led by the site medical director and available at 24/7, helping any difficult clinical scenarios with a 3 wise men approach. But it was more than 3 wise men. Actually, a clinician seeking help in a challenging clinical situation had an access to a multidisciplinary senior group, including ICU consultant, respiratory, a palliative care consultant, committee of the member of the committee of the ethic part as well, or any specialist consultant which is appropriate in the situation. And this group had a joint conversation, and a very high-level decision was made in that topic, and feedback was provided to families about how the decision was made. And when, there were fears about, that intensive care capacity scarce, or we had some difficult scenarios when a baby was critically ill and the parents, from infection control point of view, could not have visit, this supporting group made that possible, with a very senior decision making. Just a few last slides about how children's services were affected. And again, interestingly, A&E visits for children significantly dropped during the pandemic, and dropped more significantly than what we have seen for adults. And why is that? Certainly we had to make some changes to create capacity for adult patients, but there clearly was changes in patient and family behavior, and probably kind of seeking help only where more significant health problems occurred, and changes in the prevalence of some conditions, as I mentioned, respiratory viruses before. So this graph is showing the pediatric A&E visits in the last year, and you can see that with the lockdown, there was a very significant drop down in the activity. And again, our infectious disease consultants has picked up last April that they have seen a cluster of children with this unexplained inflammation syndrome. And they published this 78 patient cohort now. And we definitely have seen a larger cluster of cases in the second wave now in the UK. And it's called pediatric inflammatory multisystem syndrome, which was associated to previous SARS-CoV infection. And you can see that, again, luckily, this is not something which affecting neonatal population. The median age was about 11 years of age, and generally children had no significant comorbidities. but has led to a hospitalization and need for critical care, but with a low mortality. So nearly of the third patient had coronary artery abnormalities, and they often received immunomodulatory therapies, but responded well to this and to supportive intensive care. And just very lastly, I wanted to draw attention how heroic the London and the UK PICUs had to adopt in the pandemic. And clearly, other than the PIMS cases, there was a reduction in activity, and there was a huge pressure for adult ICU capacity. So our trust had to flex their adult ICU capacity from 50 bed till about 150 bed capacity. And this was not possible without converting our entire PICU to a red zone adult ICU, including their multidisciplinary team. And you can see here a photo which was in media, as we had Giles Dooley, award-winning war photographer, visiting our ICUs. And basically our whole PICU team has looked after for months adult COVID patients, and a couple of the neonatal consultants went to support our nurses as nurse buddies there as well. So on my last slide, I try to reflect, what we don't know. And I think now there is a group of children we can call pandemic children who were born during this period. And for their development, they really need a simulating, varied and responsive environment. And they need, for this will help them to develop language, cognition, emotional and social competencies, and to be able to flexible and adopt. And this was severely compromised over the last year for these children. And we know that they had additional issues. The parents had increased stress and potentially mental health problems related to the pandemic. There was a lot of disruption in their usual supportive system and seeing and having connections to their extended family. A lot of us healthcare professionals are worried about the consequences of mask wearing and physical distancing on these children, and just the hygiene procedures in place, which became their normal now. And just the compromised healthcare. We know that, for example, for neonates after discharge, there was a reduced lactation support, poorer developmental monitoring, and potential children came to harm because maltreatment, abuse, or neglect was not recognized on time. And here we look into resetting, recovery, and resilience. And for now, this is going to be a difficult time to go. And I really like this graph to understand how much damage probably happened during this pandemic. And there's at least probably 5 to 10 years to recover from this emotionally and healthcare structure-wise. And there will be several phases we will have to go through before really growth can happen. So I would like to thank for your attention, and I hope that I was okay with time. I stop sharing.
Mama, where's Daddy and Mom? They're hungry, but they're
Hello, Dr. Thank you so much for your presentation and really share your experience in UK. I guess you have your child with you, which is our new normal.
Yes, we had some
children, but we are taking you away from your family. I know it's Friday night for you in London, but thank you so much for all that you presented today. And congratulations on all the initiatives to keep the families together. I know you had to jump some hurdles along the way. And so we have this experience from other healthcare professionals here in Canada who said, it's not always an ICU decision on parental presence, sometimes comes from infection control. How did your unit jump those hurdles to bring both parents together into your unit?
I think it was really important to go higher up. I think, when it's a decision of, an infection control nurse who will apply to the rules and national rules and guidances, and may not happy to deviate and make exceptions. I think it was important that we have had access to the senior leadership group of the hospital and the trust, where we could have a conversation and risk assess the situation, and also respect, what the parents really need and potential long-term damage. And at that point, there was a possibility to deviate from local policies and allow and make exemptions. So I think that which made it possible for us. And certainly having any professional guidance, having a statement from the British Association of Perinatal Medicine just gave us a little bit of ground why to push for it.
Right. So how is the situation now?
The situation is definitely a lot better, and I think we can see now the effect of the vaccination. However, our ICUs are still significantly, not overfilled, but kind of above the normal capacity. We have seen a huge reduction in hospital admissions now. And again, we see less frequent positivity of our mothers or, babies who need admission on the high-risk pathway.
Okay, so let's talk about your unit, because there's a lot of conversations. It's easier to do if you have a private rooms, because if parents are more isolated in the room, but your unit is an open bay. So how do you do that?
So our unit is an old building, a relatively old building, and shared nurseries. And the number of cots are varied between the different size of the nurseries. So probably between 4 to 8 bedded nurseries. So each nursery has actually, a sign that what kind of risk level is that nursery. Is it a low, medium, or high risk nursery? So that's very clear. And we have agreed on maximum number of people who can be in the shared nurseries. But those people can be parents, can be doctors, can be nurses or therapists all together. So we tried not to limit the number of parents. Of course, we still have to maintain physical distancing, and we can't have overcrowded nurseries. But actually, it's more about the number of people in the nursery than not allowing parents to see their babies. So I think that was one key, having a maximum number of people allowed in the nursery, but not defining number of parents.
That is so great. How about extended family? Is grandparents or siblings or exceptions when there is palliative care?
So I think when these babies were critically ill or in a bereavement situation, we certainly managed to make exceptions. But right now, at the present, the unit is still closed to siblings or grandparents.
Do you have any idea how the situation is in other hospitals across UK?
So in Northwest London, our network had very similar approach. So those units are similarly now able to provide similar access to parents. But we know that it was very variable, and often parents actually had to sign up, for example, a 2 to 3 hour slots to gain access to the neonatal unit. I think each unit now, having the DIPM and Bliss statement on board, I feel should be able to challenge that and go back to at least unrestricted access for one parent all the time. So right now, again, we have to ask parents to swap because of the physical distancing. During the second wave, we were not still able to allow both of them at the same time at the cot side.
Right. So let's talk a little bit about the technology, because we implement some new technology. How is that working for the families? And the staff, actually, because also there is some difficulty sometimes with the staff to adapt to the new technology.
Yeah, so the Recreate needed a bit of training and implementation. And again, the parents have to know about it so they are able to register, because we are not able to register on that system at all. So it had a training element, but it went relatively quickly. But I think however, we were very grateful to use this system. I still feel that there was a need for real-time connection, like FaceTime, for the parents, and not just the pre-recorded videos. But it's a support, and it's something which helps to reuse the separation. So it's great that it was available. And the neonatal networks in the UK paid for a 1-year subscription for the majority of the units. So it didn't cost a huge amount of money for the units itself.
That is great. So let's talk about moving forward beyond the pandemic. How do you see family integrated care the sustainability of this model of care once the pandemic is over, or the rules start to relax a little bit, because there's some fear that we went back 20 years on parent engagement. So how are we going to pick up from where you left, or it's going to be a new model? So how do you see this happening in the future?
I think that we have to keep the positives from this pandemic as well. And I think going virtual in some aspect had some benefits. So previously we had no option for virtual ward rounds. And if a parent was not in the hospital, actually, then the parents missed the opportunity for the ward round for that day. So having this hybrid way going forward, maintaining virtual when it's actually useful, would be really, really great. So I don't think we can just simply go back. We have to find ways of improvement and combining all the positives.
Absolutely. Dr. Ayer, thank you so much for joining us here today. It was such a pleasure talking to you. I know you've been very busy and doing great work advocating for families, not only in your unit, but across the world. So we're very grateful to you and your work. So thank you.
Thank you for inviting me.
So, and thank you all of you for joining us from Facebook or YouTube. We are going to take a short break and we'll be back in just a few minutes. And I want to thank the International and National Family Integrated Care Committees for their work and collaboration with CPBF on this talk today. And also last Friday, we started part 1 of COVID-19, a year in review. And today's session was made possible thanks to our partner, AbbVie. And the video of today's sessions and all the videos from our live series are available on the CPBF website, which is canadianpreemies.org. Stay with us. We'll be back with Karen Lasby, talk about caring for your preemie baby at home in just a few minutes. Thank you. Stay tuned. Hello, everyone. Thank you for joining us here today. If this is your first session of the day, welcome to the Preemie Chats. I am Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Preemie Chat series is one of many initiatives we have to bring information for NICU families and healthcare professionals. And today we are doing a year in review of COVID-19. Today's session is a collaboration with the International Family Integrated Care Committee, sponsored by AbbVie. If you missed our first session, I interviewed Dr. Aniko Dyer from UK, sharing her experience during the pandemic in her hospital. The video is going to be available on our feed on Facebook and YouTube, and in a few days on our website. And right now, we are going to talk about caring for your preemie at home amid the pandemic. Parents are highly motivated to protect their premature babies from illnesses. This COVID-19 pandemic has heightened parental stress about taking premature baby home and out to specialist appointments. In this presentation, we'll discuss how to protect your premature baby, how to respond if someone in your home develops signs of illness, and what are the common signs of COVID infection for babies. Parents will be reassured that they have the right strategies in place to keep their baby well beyond the NICU. And I have here with me Karen Lasby. Let me bring her to the broadcast. Karen Lasby's 40-year career has helped her become an expert in the support of premature babies and their families after the NICU discharge. Karen has made presentations locally, nationally, and internationally, and she has written and taught online courses to educate nurses about how to care for babies in the NICU. She has also been a research co-investigator and has published articles related to premature babies, and she served on the executive boards of the Canadian and International Associations of Neonatal Nurses. Karen and her colleague, Tammy Sherrow, co-authored an essential parent book for parents of premature babies titled Preemie Care, a guide to navigate the first year with your premature baby. Karen, joining us from Calgary, welcome, and thank you so much for joining us here today.
Oh, thank you very much for having me on. I'm delighted to be able to share some perspective about taking your baby home.
That is wonderful. Karen, I know you have a presentation to share with us. I will let you share your screen, and then we are going to have a period of Q&A at the end, so you can feel free to send your comments and questions on the box below your screen.
You bet. I'll get that going. All right. Can you see my slides?
I cannot.
Oh.
Okay, let's do this. Share button at the bottom of your screen, and then application window.
Yeah, I did that. Okay.
This is our new technology, and this happens all the time. We test the platform, but of course, sometimes things happen. Okay, I see it's coming. Here you go. Karen, you can now, yes, there you go. You're ready to go.
Excellent, thank you. Sorry for the little glitch there. Well, welcome everybody. So, you know, parents historically have shared with us how stressful it is, how you know, just taking your baby home from the NICU. Are parents ready for this? Is their baby ready for this? You know, is there what kind of help are you going to get after you go? You know, leaving that neonatal intensive care unit with all those multidisciplinary professionals is a little bit formidable as you're leaving. And this pandemic has escalated that kind of that concern about taking your baby home. You know, in the NICU that you've been watching the staff wash their hands, you've been trained how to wash your hands properly. We're putting on masks, face shields, whatever we need to do to protect our babies, our staff, and our families. So the time comes for you to take your baby home. And now this is just another little elevation of apprehension as you take your baby home. So what can we do to, what advice can I share based on my career in terms of what can we do to protect our babies and our families after they go home? I do want to add one little disclaimer, is that the information that I'm going to provide today is valid today. I have double checked the literature, and I'm trying to provide the most up-to-date research possible. But as you know, in the past year, things have been changing weekly, monthly, sometimes daily, in terms of what the recommendations are, what we learn about this virus. So it is a constant a change as we move forward. So first of all, families, let's be proactive, and let's really pause to think about what will you do as you take your baby home, or if your baby's home already, what will you do to protect the health of your other children, of the other adults that are in your home, of this premature baby that you're bringing home. We don't want to wait until we discover, somebody's got a runny nose, someone's got a cough, someone spiked a fever, and then go, oh no, what do we do? It's really advisable for you to be proactive. Let's put a plan in place. So first and foremost, follow the current public health recommendations, and that will significantly reduce the risk of contracting any illness. And so these recommendations include right now good hand washing, masking, physical distancing. So those three things have made us had a powerful impact on disease transmission. Making sure that everybody is up to date with vaccinations. There is a bit an alarming trend that families and adults and children are not keeping up to date with vaccinations. Perhaps they're challenged in booking an appointment. Perhaps they're fearful of going to their clinic or their doctor's office for vaccinations. Perhaps they just want to leave the house. And that has caused public health concern that we're going to see a resurgence of other types of diseases that we have kept in control, like measles, diphtheria, the flu. Interesting thing has happened with the RSV, or respiratory syncytial virus. This is a very common virus, causes symptoms like a cold. And what we're finding is, because of our public health recommendations of masking, washing our hands, staying physically distant, we're noticing that the RSV was really suppressed this year. We're not seeing a big uprise in RSV like we usually do year after year, and run this national RSV program. So interesting. I don't remember the last time I was sick. It's been more than a year. So there are some real big benefits, believe it or not, of our public health recommendations. So what does thoroughly wash your hands mean? I know parents of premature babies, you get that training drilled into you, and it's not just simply about running your hands through water or throwing on some hand sanitizer. It's also about friction, right? So really getting through and cleaning under your nails and making sure your hands are as clean as possible. And if you're going to touch your face, well, that hand is no longer clean. So I know parents of premature babies are diligent with their hand washing. I swear they could come in and run courses on how to wash your hands properly. Even my own family members, it is a surprise to non-medical people and non-parents of preemies really what good hand washing means. And we've all, as a nation, we've learned that this year. Hand sanitizer, yes, keep it handy. Keep it in your diaper bag. Keep it in your car. I have one in my car. So as soon as I get into my car, first thing I do is I hand sanitize before I drive anywhere. And I don't think that hand sanitizer is going to go away. We're going to be keeping that supply really handy. Making sure everyone is healthy at home. That means physically and mentally healthy. We're only, we're all a complex interplay of our physical organs and our functions and our mental capacity and our overall health and nutrition. Just making sure that everybody is eating well, eating nutritiously, eating regularly. I know moms and dads, when you've got a preemie in the NICU, you tend to forget meals, or you're skipping them. You're not eating well because your stress levels are high. Really important that you take care of yourself and the rest of your family. Drink lots of water. and get as much rest and sleep as possible. I know that's a challenge when you've got a baby in the NICU and you're fraught with worry, or you've got a baby at home and they're interrupting your sleep, but rest as much as possible, and that really boosts your immune system. Research has also shown that vitamin D levels are really important for our immune systems. We know that research has shown that babies' vitamin D levels can lower their risk of RSV, a common virus, a respiratory virus. And adult research with COVID-19 virus has also shown that low levels of vitamin D is associated with an increased risk of COVID-19. So vitamin D, it is recommended for all of our babies, and it's definitely something we should think about as adults. We don't get enough sun. I know you've all been out walking a lot more during this COVID pandemic. However, it is a challenge for us to get enough, especially if we're bundled up, or only our face is exposed. That's not enough vitamin D exposure. So vitamin D supplementation is often recommended. So talk to your healthcare professional. So you've put the plans in place, you've got plan A, plan B, and somebody has turned sick in your home. What do? Your preemie is at home. And so suddenly somebody has got symptoms of a cold, they've got a fever. What can you do to protect your preemie at home? So first and foremost, reach out to your healthcare professionals. Maybe it's a conversation you've already had with your baby's doctor or your baby's nurse to say, what should we do in that case? These are the particulars about your home, and these are the limitations. This is what you can accommodate, and so that you've got a plan in place. But if it's happened, and you should reach out to your family doctor, reach out to your pediatrician, your baby specialist, reach out to your public health nurse, and proceed with your area's instruction about symptoms of illness. So we do highly recommend that symptomatic people get a COVID screen. And in some of our areas in the country, we may be doing some asymptomatic testing. So if your older child has symptoms of a runny nose, can only that child be tested, or can everybody else be tested? Just to give you an idea of what's happening. But keep in mind that test is only one point in time. And that, 48 hours later, maybe that more people might be symptomatic and might actually be COVID positive. So follow the advice of your healthcare professionals about what you should do for your baby. You'll want to isolate the sick person. And this is a challenge in many apartments, small homes, but you got to be creative. So you try to keep the baby separate. And if you've got a preemie, sometimes the best thing to do is just to keep the preemie separate, right? Keep the baby in the master bedroom. You're not bringing the baby all around the house because the 3-year-old's coughing and sneezing and it's got a runny nose elsewhere, and it's hard to contain a 3-year-old in one room. It would be totally impossible. But if you've got an older child, a teenager, yes, isolation is much more possible because they certainly understand the instructions that you're giving them. So try to keep the baby separate from the other healthcare members. If possible, if it's an older person, if that sick person could have their own separate bathroom, that would be ideal. But many of our apartments and homes just have the one bathroom. So if you only have one bathroom, you'll want to make sure that you replace the hand towels with paper towels in your bathroom, so that we're not all, the sick person and everybody else is using the same hand towel to dry. So I would just remove all the towels. Everyone can keep their own towel in their own room or in a different location in the house. They can bring their towel into the bathroom, and then they would remove it. So just use paper towels. I would have disinfectant wipes in that bathroom so that everyone can wipe down very frequently, preferably before and after use. And that way the sink handles, the toilet handle, just general touching of the counter space will all be clean and optimize or decrease disease transmission. Always wash your hands before baby care. You parents, that already. That is an automatic for you. Everyone should wear a mask when they're near the baby. Most of our viruses, the common viruses that we have, are spread by respiratory droplets. So even though mom and dad, you might be asymptomatic, maybe only the 3-year-old has got that runny nose or that cough, but as the other people in the home could have that same virus, could transmit that same virus, but they don't have symptoms. So it's a hidden secret there that that virus is actually in you. You can transmit it when you're talking and laughing and coughing. You're touching your face, you're touching your baby, disease transmission. So if someone is sick in your home, the masks should come out in your home to ultimately protect other people. Remember, masks are for protecting other people primarily. So this is just being extra cautious, right? Because you don't want your preemie to have to go back into hospital. And asking for help from outside the home for errands. Can somebody else pick up groceries? Can someone else pick up that prescription? Can someone else bring some meals in for you just to ease the stress that you're going through? So, and in the case of a COVID positive person in your home, everyone is considered a contact. So you're under quarantine. So even if you were tested negative, you've got a COVID positive person in your vicinity, then everybody, you can't go out for errands. You need to rely on other people. So, and that can be a challenge, especially for single parents, students who have, people who live alone with their premature baby. And that's, as we all know, the challenges of quarantine in the past year. This has got to be the hardest thing, right? What if mom becomes unwell? We know that close contact is so important. Your previous speaker, Dr. Dyrell, spoke about skin to skin and wanting to minimize separation with the mother. Absolutely. So when mothers become sick, we can't isolate. And they certainly have been lots and lots of studies in the past year. We've learned a lot about what happens if mom is unwell. What if mom is COVID positive? What then for the baby? So we know that mothers need time to rest and recover to take care of their own health needs, certainly. So if the mom is well enough to hold her baby, then just like this picture shows, we would recommend mom wash her hands, mask, and yes, that close contact is very, very important. If she is well enough to breastfeed, we have great advice, lots of current studies that show that direct breastfeeding, even if the mom is COVID positive, is safe to do. The risk is low. So yes, mom will wash her hands. Some studies have actually indicated washing the breast. And yes, the baby can breastfeed. The studies are not showing transmission of the virus highly in the breast milk. So they say the risk is very, very low. And this comes from the Center for Disease Control, World Health Organization, the American Academy of Pediatrics. So these are coming from very credible associations. So breast milk provides protection against many illnesses and is the best source of nutrition for babies. So moms may decide to pump and somebody else can bottle feed the baby, but we do highly encourage our moms, even if they're unwell, as long as they're physically able to hold the baby and work on some breastfeeding, we do encourage that close contact. And I'll just, again, contact your healthcare professional. If mom is unwell, contact your healthcare professional for the most current information, right? Next week, there might be new studies coming out. And the next worst case scenario, now your premature baby is unwell. Parents, your baby the best, and when your baby is unwell. And I hear parents saying, she's just a little off, or he doesn't usually act like this. And the spidey senses are tingling, right? And you're saying something's not quite right. But you're afraid. You're afraid to think about taking your baby to the hospital. You're afraid to think about taking your baby to the doctor. You don't want, if it's not COVID, you certainly don't want them to catch COVID in such environments. But your baby best, and you need to trust your instincts. If your baby is unwell, yes, they need to have medical attention. And I will be talking about these symptoms in a second. So don't avoid seeking medical assessment. So whether that be the emergency department, whether that be doctors' offices, they have had a whole year to get their cleaning practices and their physical distancing perfected. So family baby home right now, you can rest assured it's not like it was 12 months ago where we're all kind of scrambling to go, what do we do? What do we do? How do we protect everybody? We know now. So rest assured that you will be in very good hands. When the triage nurse sees your baby and you at the beginning of the emergency department, they will make sure that you are in the safest location for your baby. And so research tells us that COVID positive babies have subtle and mild symptoms. And I must say the research is very mixed about whether babies are more susceptible or less susceptible to COVID. So, for example, there was research coming out of China and Italy. They suggested that babies under 1 month of age are at greater risk of catching COVID and are greater risk of severe types of COVID. But research coming out of France and the United States is saying the opposite. They're saying that the younger babies were at the lowest risk and they had the least severe illness. So it's all over the map. But, and also important to know that most of the research is looking at babies in general. Full-term babies, premature baby, we're all lumped into the same research. I could not find any research specific to premature babies' incidence of COVID post-discharge. And maybe that's a good thing. Maybe it's because we're not seeing a lot of COVID in our premature population. Keep in mind that the United States, just looking at the United States and China, where we've had really high rates of COVID, less than 2% of the cases were in children under 19 years of age. So it's it is the takeaway message is COVID is not common in babies, and I guess that's certainly the good news. So what are they seeing for those very few babies that do become COVID positive? They are very subtle, and I'm listing them in order of they're saying about 50% of babies have tummy troubles. And, that's often one of the first things that parents are saying to me is that, they're just not feeding as well. Something's not right. Sometimes it's the feeding part that's affected. Their appetite's down. They're just not, maybe they're spitting up more. They're throwing up. They just seem to have some tummy aches. So don't excuse that as, it's just a little gas. Pay attention to the symptoms like that. Mild fever, we've certainly heard that 63% of children present with a mild fever, and 73% present with breathing concerns. So whether that they're having wheezy breathing, noisy breathing, they're breathing heavy, they just seem like they're really worried about breathing. They may have an anxious expression on their face, and they're breathing fast, and they may have a cough, they might have a runny nose. And certainly not breathing is a 911 call. Some of the other subtle symptoms, a little bit more irritable, just not right, maybe kind of floppy, usually they're feisty and they complain and they're like just laying there kind of sad. Pay attention and talk to your doctor about that. I just wanted to add one little caution. And there is so much information out there about COVID, about babies, about public health regulations, about vaccines. Be sure you're using reputable sources. And I would point to your provincial or state sources. I would point to the Canadian national sources. Even, looking at the United States, if you are a Canadian, maybe the United States research regulations don't apply to us. We certainly see great diversity in what public health relations are from state to state, and we've got a little bit more of a universal approach to COVID protection in Canada. So just if you're living in Canada, this is a place to get your reliable information. So just be careful about Dr. Google. Dr. Google you can go down a rabbit hole when you get onto Dr. Google. And I've said in the introduction, I've said all along, parents of premature babies, they get how to protect their babies. And so you're taking your baby home from the NICU, you've got your baby home with you, you've got this. You know how to protect your baby. So what are some of the other little tips? Vaccinations, again, we are seeing an alarming decrease in vaccinations, and especially in the United States. And so we don't want whooping cough and diphtheria and measles to surface again. Those are serious illnesses as well. And we certainly don't want them resurfacing. So, talk to your healthcare professionals about keeping your baby up to date and your family up to date. The typical routine vaccinations in Canada are 2, 4, and 6 months. Many premature babies were eligible for the RSV vaccination on a seasonal basis through our winter. But and just know that, just stay current with what the recommendations are. What about taking your baby out to appointments? You leave the NICU and you've got this list of all these specialist appointments that you need to attend to. And parents are afraid. They are verbalizing that I don't want to go to the doctor's office. Sick children go to the doctor's office. I don't want to go to the hospital for children because lots of other children are there. But know that clinics are taking extra precautions. They are physically spacing out. You may not be able to weigh and measure your baby at, say, a routine vaccination appointment. When you have your vaccination, we find here in Alberta, you're often staying in the same room after the vaccination, and then instead of waiting in the waiting room. Dr. Dyer also commented about decreased lactation support. That is a big problem during this pandemic. So many of our mothers benefit from continued support for their breast milk and breastfeeding options. So access to an LC may be problematic. Yes, there are Zoom appointments, and maybe you're thinking, I'm not feeling comfortable about breastfeeding on camera like this. I have a solution for you. When you connect up by Zoom, I want you, maybe your partner or somebody else in your family could connect by phone. And then instead of being on a screen like this and exposing yourself, you get your phone and you get them to zero in on the lactation, on the latch. It's way more, you got lots more privacy than, thinking, am I okay with this? You can still get very good support from a Zoom call. I have done Zoom appointments for breastfeeding latch and position, and we do fantastic. It's really, really good. It's certainly better than nothing. So, and many of our appointments, many other specialist appointments like the follow-up clinics or therapists, some of those are done by Zoom. And I know even myself, the Zoom appointments that I've been doing, you can't do it all. You can't do proper developmental screening. You can't do a proper head shape assessment. It is challenging. So hopefully there's going to be a mix of in-person and Zoom appointments to make sure that your baby is getting comprehensive care. And just finally, you are your baby's best advocate. So if Zoom is inadequate, if telephone appointments with your doctor is inadequate, speak up. And I know you've got this. I know parents are great advocates, and they're going to, voice their concerns and not be content with just a quick little phone call when you've got something that's quite visual that you want to see. I get pictures of poop and head spit ups and you name it. I get pictures texted and emailed to me almost on an every other day basis. And so, so we can do a lot virtually, but some of it you kind of need to actually see the baby. So when you do go to these appointments, follow your public health regulations. Don't go to the appointment if anyone has a sign of illness. They may restrict you to one adult in appointments or in clinics, and that's very common across our country. And certainly no other children are allowed. That is a hardship for single parents. And so it is a challenge for them to find daycare or a babysitter so that they can go to appointments. We have to be very creative there. And bring hand sanitizer with you. and just be physically cautious about people around. I know whenever I'm in a room and I hear somebody cough, I'm like, like before I maybe wouldn't even paid attention, but now like I just heard someone cough, and I know parents, you're going to be feeling the very same way. So, and so that is the end of my presentation, and I'll turn it back over to you, Fabienne.
Hi, Karen. Thank you so much for your presentation, for your very practical tips. I think this is very much what parents needed to hear. And listening to you, I feel, okay, I was in the NICU 8 years ago with my son, and I remember the same recommendations about the hand washing and, how to protect the baby if you have a sibling at home and bringing visitors into the house. So great tips. I think more than ever is so important. And I do believe that ICU is really trained us really well in hand washing and how to protect our babies. So Karen, unfortunately, we don't have a time for a Q&A, but I know you're coming back in May because you always have so much to share. But I do want to share with our parents your book, Preemie Care. I think it is such an important book, the Canadian reality, what happens in the NICUs and where to find the resources in Canada. We love your book and we highly recommend to parents to check it out. There's so much information there for families, so many resources, and you address so many important topics from the NICU time to all the time babies go home and beyond, follow up and etc. But I'm so grateful that you joined us here today. I will bring you back in May for sure because I have lots more to talk about.
Lots more. Thank you very much for having me.
Thank you, Karen. And for all of you watching from home or in the hospital, either on Facebook or YouTube, thank you so much for joining us here today. We are going to be back in just a few minutes with Dr. Prakash Shah and Dr. Faith Zhu. And I want to thank the International and National Family Integrated Care Committees for their work and for collaborating with CPBF on this talk today. And today's session was made possible thanks to our partner, AbbVie. And the video of today's sessions and all the videos from our live series are available on the CPBF website, which is canadianpreemies.org. So stay with us. We're going to be back in just a couple of minutes. Thank you. Hello, everyone. Thank you for joining us here today. Welcome back. If you have seen our last two sessions, and if it is your first session, I am Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Preemie Chat series is one of many initiatives we have to bring information for NICU families and healthcare professionals. And today we are doing a year in review of COVID-19. Today's session is a collaboration with the International Family Integrated Care Committee is sponsored by AbbVie. If you missed our first 2 sessions, I talked earlier with Dr. Aniko Dyer from England, sharing her experience of parental presence in the NICU during the pandemic. I also just talked to Karen Lasby, author of Preemie Care, book, which is a book full of resources for families, and she talked about transitioning from the NICU home and how to protect your baby during the pandemic. All the videos will be available on our website in a couple of days, but it is available right now on our feeds on YouTube and Facebook. And right here today, right now, we're actually going to talk with Dr. Prakash Shah and Dr. Faith Zhu. They will be discussing the controversies surrounding COVID-19 and breastfeeding and the impact that this pandemic has had on breastfeeding. They will also be sharing their recently published study investigating the presence of COVID-19 virus and antibodies in breast milk. And I'm going to bring them to our live broadcast. Dr. Faith Zhu is a senior neonatal fellow with the Neonatal-Perinatal Medicine program at the University of Toronto. She graduated from the University of Edinburgh in 2009 and underwent training in Paediatrics and Neonatology in the UK until 2018, when she immigrated to Toronto to join the fellowship program. Her research interests include neonatal hemodynamics and the impact of early nutrition on the development of the newborn cardiovascular system. Dr. Zhu, thank you so much for joining us here today.
Thank you so much for having us. It's such a pleasure to be here and discuss it.
Thank you. And I also have here with me Dr. Prakash Shah. He's the Chief of Pediatrics and a professor in the Department of Pediatrics at Institute of Health Policy Management and Evaluation at the University of Toronto, Canada. He's a director of the Canadian Neonatal Network, CNN, and an international network for evaluation of outcomes of neonates, the INEO, whereby he oversees a project of benchmarking outcomes of very low birth weight neonates in 11 countries, with a final aim of improving quality of care to neonates and families worldwide. He's engaged in several policy and advocacy work with his role in executive committees and advisory board membership at local, provincial, national, and international levels. Dr. Shah, thank you so much for joining us here today. I am so grateful. You are both very busy, and I'm so grateful you took some time to share with us your latest research.
Thank you very much. It's pleasure to be here. And hi, everybody.
Thank you. Dr. Zhu, I will let you share your screen. And I know you have a presentation, and then at the end you have a Q&A. So please feel free to send your comments and questions on the box below, either on YouTube or Facebook, wherever you're watching us from. So let's see if this is going to work.
Try this. Let me know if you see it.
I see it. Give me 1 second. Yes. Can you share from the first slide?
Yep, absolutely. Can you see the slides? There we go. Oh.
No, we're still on the. Okay, now we are on slide 1, but not on slideshow.
Let me put that up. How's that?
No, it's not going in the slideshow.
Nope. I think we'll need your help, Fabiana.
Thank you very much. Yeah, now we can see. Thank you very much. So thank you very much, Fabiana, for that kind introduction. And thank you for asking us to give a little bit of a spill on breastfeeding and the COVID. What Dr. Zhu and I would be doing will be presenting you some information as to how all this started, as we have already approached the anniversary of WHO declaring pandemic, and during that year, where did it start, how did it start, and how did it evolve, so that we can now confidently acquaint our parents as well as the healthcare provider as to what is the correct thing to do. Next slide, please. So it all started with a lot of myths and a lot of news. One Japanese mother milk tested positive, and that became a news. But some experts at that time also warned that please stay calm. We don't know what happens. However, Daily Mail at the same time reported a mother that reported that her breast milk turned green when she contracted COVID-19. Now, this kind of news did attract a lot of media attention, did attract questions from a lot of parents across the world, and appropriate concerns that are we doing the right thing? What should we be doing? Now, as you all know, it all started in China, in Wuhan. And when it started in Wuhan, what first thing they did with the mothers who delivered babies when they had contracted COVID, either during the pregnancy or at the terminal stages of pregnancy, they basically separated baby from the mother. So the baby was completely separated from the mother, kept in isolation in another room, and mother was not allowed to touch or see the baby for 14 days. As a result of that, there was no reports, and they basically claimed that there was no report of transmission of infection going from mother to the baby, either through the placenta or through breast milk, because the breast milk was completely out of question. There were a lot of other reports that were coming up. What are the ways to protect your baby from coronavirus? There are things to remember, what mother should do, and what mother should keep the baby 6 feet away from her. So all this created a lot of confusion, and reports from China suggesting no transmission of infection from the mother to baby also led to belief that we need to separate the babies, and we don't need to we should be feeding these babies breast milk. Now, next slide, please. So with that in mind, there was a nice study done by Popowski in 2020 looking at what did mothers do during this period regarding the coronavirus infection, and what were their intention before, what happened actually in the hospital, and what happened when the babies went home. And what it identified clearly that there was a higher rates of breastfeeding in those babies in whom mother and baby was not separated, 22% versus 0. And additionally, there were higher rates of formula feeding among separated, 82% versus 28%. So these news, as well as the guidance from the organizations, national organization or authorities, did create confusion. Next slide, please. And it is reflected in such a way that a nice report that came out in August 2020 in one of the journals in NSAT, which said that if worldwide we have reduction in breastfeeding to the amount of either 5% or 50%, what would be the impact? And a startling number in the low middle income countries, just reduction in breastfeeding by 5% will lead to more than 16,000 deaths. And imagine if it goes to 50% reduction, there will be more than 100,000 babies who will die just because they were not exposed to the protective coverage that they get through the breastfeeding. And this is huge, and this does need to be taken into consideration prior to making any policy or any decision or any discussion. That what are the advantages and what kind of disadvantage we are putting the baby into. Next slide, please. With that, as the time goes by, as I was trying to tell the story, initially, American Academy of Pediatrics and certain organizations in America basically came up with a recommendation that infants should not be fed with breast milk from mothers with either confirmed or suspected SARS-CoV-2 infection until you test mother and you taste breast milk and it is negative. Now, these were early days because at that time, there was no information available. The only information was the way it was managed in China. When it started, the incidence started to increase in European countries, in Italy and France, we had a lot of discussion with the physicians over there. And the community in Italy and France in the initial days were split. They were 50-50. Some units were allowing mothers to continue with the breastfeeding, and some units were separating those babies completely. So until later, when we started to know that the condition affecting the newborn babies is not only rare, but it is very, very rare to be severely infected. So by July 22nd, 2020, American Academy of Pediatrics recommended that separation of mothers, but now supports rooming in and breastfeeding. So they changed their stance. Similarly, CDC until December 3rd, 2020, supported express breast milk and further discussion. Updated guidance support evidence that the breast milk is not a likely source of infection or transmission. WHO has been from beginning trying to support rooming in and breastfeeding. So is Canadian Pediatric Society. We at that stage balanced the risk as well as benefit ratio and suggested that we need to support the breastfeeding even if the mothers have COVID-19. In initial days, we did highlight all the precautions that this mother should take while breastfeeding and to make sure that there is no heightened or direct transmission that can occur because of the symptoms in the mother. Next slide, please. With that, what we thought that now we know a little more about it, and we undertook a project which Dr. Zhu will present the findings of that project now.
Thank you, Dr. Shah. So, as what Dr. has alluded, there's been a lot of questions and a lot of queries and worries that families have, whether they should breastfeed their babies in these very unsettling times. And the aims of our project really is to answer two questions. One being, how common is the virus, COVID virus, found in the breast milk? And the second being, how common are the anti-COVID antibodies found in the breast milk? The next slide, please. So, we all know COVID is mainly really transmitted through respiratory tract, so hence the guidance of hand washing and wearing masks. But there are also important infections that have been known to be transmitted through breast milk. Quite famously, there's HIV virus, which led to a decrease in breastfeeding.
Sorry, Zhu, can you speak closer to your microphone because you're losing your audio every now and then?
Sorry, it might be my internet.
Oh, that's better now.
Okay, sure. So as we mentioned, transmission of COVID is really mainly through the respiratory tract, but at the same time, we know that there are infections that are passed through the breast milk, HIV being one of the most famously known ones, and back in the 80s, that certainly changed a lot of practice in terms of how we advise families in terms of breastfeeding. Although now, these days, in low middle income countries, when breast milk substitute is not really able to be carried out safely, in some HIV moms who are on treatment, the WHO does talk about the potential for using breast milk feeding in this setting. And what about in the previous COVID virus, coronaviruses? So in the SARS in 2003, and also with the Middle Eastern respiratory virus in 2012, there's really very little that's known about its presence in the breast milk of the virus or the antibodies. With regards to the SARS in 2003, only 2 studies were done looking at both the virus and the antibodies, and really only 1 sample of virus and 1 sample of antibodies was seen. And in the Middle Eastern respiratory illness in 2012, there really hasn't been any looked at in human milk, but seen in more kind of animal studies and camel milk. Next slide, please. Saying that, we also know that there are many protective factors in breast milk, in particular with relation to infection. The ones that you've probably heard of most are things like the human milk oligosaccharides, or the HMOs, which really work by preventing the infection cells to attach to the human gut as well as the urinary tract, and also establishing good kind of bacteria in the gut too. The lactoferrin that you also may have heard about looks at, it works by binding to iron, which is really necessary for bacteria and viruses to proliferate, and so prevents the proliferation of these pathogens within the gut, within the baby, if they have lactoferrin in their diet. And then lastly, the immunoglobulins, the antibodies that we talk about in our study. As you can see, there are lots of different types that are known of antibodies that are there. But we also do know that in respiratory illnesses, especially in moms who have received the vaccines in pregnancy, this continues to be passed through the milk and protect babies after they're born up to at least 3 months of life. And also in HIV moms who have antibodies in their blood and in their milk can also continue to protect their babies and prevent maternal to child transmission after birth. Next slide, please. So just talking about our study, we did a literature review. This was between January and October of 2020, and we had screened over 800 studies and found a total of 50 international studies that were carried out over 15 countries around the world that included 213 mothers. And these were mothers who had confirmed COVID infection through confirmed testing. And also we wanted moms who had their breast milk tested for either the virus or the antibodies. Next slide, please. And from our study, what we found that there were 183 mothers who had testing for the virus itself, of which only 12 moms had samples that were positive for the virus. And when we took all the studies together, this gave us a pool proportion of 5%. And of these 12 moms who had the positive COVID virus found in the breast milk, 6 of their infants tested positive, and 4 of these infants were symptomatic. And the symptoms were generally quite mild, with things like either some low temperature or some feeding issues. And one of these 4 babies needed breathing support. And this one baby that needed breathing support actually also had a separate virus infection at the same time. And when we looked at the moms who were tested for anti-COVID antibodies in their breast milk, there were 61 moms who had their samples which came back positive for the antibodies. Again, this would give us a full proportion of 83% of the moms. And of these 89 moms, of these 61 moms, 3 of those infants tested positive, with only 1 child being mildly symptomatic. Next slide, please. So from what we can see in our study is that the presence of the virus in the breast milk is quite uncommon. And actually, the anti-COVID antibodies in the breast milk may actually be more prevalent than the virus itself. And what we have suggested in our study is that breastfeeding should be recommended to moms after education about hand hygiene and really kind of safe practices around breastfeeding. And next slide. So there's still a few questions that are out there following our studies. One being, is the presence of the virus in the breast milk, is it an active virus? Does it cause infection in newborn? And really no one can answer this question at this point. It's always really hard for these type of studies to say that, you know, presence in the milk equals to transmission to the baby, because there are a lot of other factors that can possibly contribute to the baby being positive for the infection. The second question would be, how long do these antibodies remain in breast milk? And the third being, what do these antibodies do? Do they neutralize the virus, and do they have a protective role play in the whole scheme of things? And I believe in May we have one of our attending neonatologists here, Dr. Anga, who will talk a little bit about her study, which looks specifically more at kind of breast milk antibodies in COVID positive moms. So that is something to look forward to in the next couple of months. So thank you very much. We're always very happy to take any questions at this point. Yeah, I guess the floor is yours.
Okay, thank you so much, Dr. Shah and Dr. Zhu, for this presentation. I think such an important topic for us to address and to really educate the healthcare professionals in the community, but also the parents. So do we have a consensus now worldwide that breastfeeding is safe? Okay, you are mute, Dr. Shah. Can you unmute yourself?
Yeah.
Okay.
So sure, yeah. So do we have consensus? I think all the organizations are now suggesting that breastfeeding should not be withheld for the mothers who would like to breastfeed, and rather it should be encouraged. Because so we are, no organization now is asking for separation. I'm still not 100% sure what is happening in China. However, their incidence of SARS-CoV-2 is so down, so they probably may not need to update their findings or organization. But for the areas where it is still prevalent, like happening in India, happening in UK, Brazil, USA, Canada, we are strongly or actively encouraging breastfeeding if mother's plan is to breastfeed.
Well, I guess my question is because we also have seen some data that breastfeeding rates is declining in a lot of places. And obviously the numbers that you gave is pretty astonishing. If 5% it was 5%, right, for low-income countries of mortality for babies, of 16,000 babies. How about the impact on countries like Canada?
Yeah, so I think in Canada, if you probably we need to look at what happened during the pandemic in the initial years. So we need to go back to 2019 breastfeeding rate and then see what happens in January, February, March, April, May for the breastfeeding prior to discharge. There was a lot of anxiety, a lot of concerns, and a lot of mothers elected not to breastfeed because they just thought that, okay, well, even if there is a remote chance of my child getting it, I don't want to do it. There were certain mothers. However, in the clinical practice, what we have found, I mean, at Mount Sinai, we haven't seen any mothers saying that, no, I don't want to.
Mm-hmm.
So I would suspect that it probably will pick up and will come up back to where we were before.
So how can we encourage, the bedside nurses to encourage the parents to continue pumping and breastfeeding? Because we've been noticing, parents have been telling us there's not enough lactation support, not only in the NICU, but mainly in the community when they go home. So how can we continue to encourage that practice and show parents that it is safe?
Yeah. Faith, you want to?
Sure. So hopefully, through these live chats too, that we're reaching out to communities, reaching out to not just healthcare professionals through our research, but also through talking about it, that, we can certainly encourage parents from all over the world to look at breastfeeding a little bit more differently than it has been, over the last year. Well, certainly from our NICU point of view, we have, like what Dr. Shah said, been encouraging families, through, even before the babies are born, if we know that, through our antenatal consults, talking to potentially premature babies' parents about breastfeeding, and, supporting all of that. We're hopeful that, all of this word that gets out there will continue mitigating the fear that is out there for families.
So
I think it is very important. I think what Karen also mentioned in the previous talk, that there are Zoom consults available, and there are ways of doing those Zoom consults in a way that is not intruding the privacy of the mothers. And I think those are the support measures that we need to enhance, activate, and encourage parents to take advantage of.
Absolutely. But Dr. Shah, for the moms who are pumping in hospital, any protocols or guidelines for cleaning the pumping equipment, or even at home? How is there any protocols in place? Where can you find those guidelines?
I think there are no protocol. Whatever there is no change because of the SARS-CoV than what it used to be. Previously also we used to encourage the mothers to clean, to make sure that everything is clean, everything is as infection-free as possible that they can do, and cleaning the pump and like the way they used to do. So there is no special, except that if there is a household with infection, then they need to take extra precautions to make sure that there is no contact, there is no direct contact, and there is avoidance as much as possible. Because for this virus to be present on surface, there is all sorts of stories going along as to whether it is there, why are we cleaning, what are we cleaning, is it present or not. I don't think we have settled. However, the science is pointing now towards more and more saying that it does not survive on surface for a long time. It's basically the direct contact, and that droplet contact is the main source of transmission.
Okay, you might have mentioned that in your talk, but is there a recommendation now to, if a mom is positive, to breastfeed using a mask?
So most of the recommendations will suggest that if mom has active symptoms, so let's say if she's sneezing or coughing or having breathing difficulty that allows her to breastfeed but not too much kind of thing, then it is recommended that she wears mask. Correct. But if she doesn't have an active symptoms and she's not looking like actively shedding viruses, then preferable but not absolutely necessary.
Okay, so I have a great question here. I understand that COVID-19 vaccination is not approved for people under 16 years old. Is there any information around the baby's exposure to the vaccine through breast milk if the mother were to be vaccinated? If the baby can be exposed through breast milk, would it be detrimental to their development or overall health? Great question, Mel. Thank you so much for asking that.
Yeah, thank you. Faith, go ahead, whichever you want to take.
Yeah, I was just going to say that I think, we're still only a few months in to the vaccine being available. And from what we know so far, the different types of, the different types of vaccines, and they haven't included pregnant or lactating moms in their studies. However, those that have become pregnant after the vaccine or have unintentionally was pregnant around the time of vaccine, we haven't seen any necessarily harm caused either to the moms or to the fetuses and the babies. But really, it's still very early days. I think internationally, there's also slightly different guidelines that are out there, depending on the country or the province, state that you're in. At the moment in Canada, for pregnant moms, certainly from the College of the Obstetrics and Gynecology here, there is no restrictions that we have put on moms receiving the vaccines. But it's still very early days, I would say, and hopefully with more studies coming out sooner than later, we'll get a bit more information about breast milk. But from what we know, there's not been any harm that has been passed through the vaccine to either the fetus or through breast milk.
With that, I think that is a great information and something that we should be looking at, because a lot of parents, and we all know through our advocacy that parents could be giving a priority to stay present in the NICU, both parents in the NICU. So this is one thing that, is on the radar, like parents should be giving priority. But if mom is pumping and breastfeeding, how safe is that at this point?
Yeah. No, it is as Dr. Zhu mentioned, it is not completely known yet. And whether the vaccine, I think the question was whether the vaccine will provide protective antibodies through breast milk to the baby.
Mm-hmm.
I wish that is true, and that somebody studies and gives that result, then we will be strongly encouraging mothers. Oh, you should be vaccinated so that your baby is also protected with the one dose kind of thing. Now, the second part of the question was that even if the virus is transmitted through breast milk, does it cause any harm in health for the baby? So what we found was there were only few babies who had some symptoms when their mothers were found to be positive and babies were found to be positive. Whether they acquired the infection through breast milk or even prior to being born through the placenta or through the uterus, which is very difficult to be 100% pointing it out. However, we are going to look at all the babies born to mothers who have been in Ontario. Now babies are coming to 1 year of age, and we'll be calling them at 1 year of age to look at their neurodevelopmental outcome, how they are doing, whether they have respiratory infections in the first year, how their heart is coping, how their health is coping, how their lungs are coping, and how they are growing and developing. So we will be getting more and more information as time goes by, because now we have certain babies who are 1 year old.
Absolutely. I'll be very happy to have you back here to share that information with us. But Dr. Shah, I want to share with you, because there's so many challenges for parents across the country, and I want to share this one. There was no place to sterilize pumping equipment due to resource room closures in the NICU you're in. Pump rentals were not available, and if you didn't have a local address, there were a lot of strange changes. And Lori is a mom who was actually in Kenora, and NICU. We know her. She was one of our speakers here, and she was transferred to Winnipeg. So there's so many challenges happening still across the country that makes things a little bit difficult for parents. How can we work together as a community of parents and you healthcare professionals to make those challenges less challenging, I guess, or lessen the burdens on the parents?
Yeah, no, I think I completely sympathize with Laurie. And I mean, even though I was not involved in the care, I'm sorry for what she experienced and what other parents have experienced throughout, I mean, not only in Canada, but elsewhere as well. I think this was a stress test of our healthcare system and all of us. Because when it came, we had no clue what we were doing. So what we went to is switch this light off. We had like a hospital switch the light off. They didn't think of dim button. Let's go by dim button or open by dim button and go slowly, because everybody was afraid and there were people dying. So people were trying to protect either themselves, patients, as well as the care providers. And in that process, the first thing was to halt the transmission, was to prevent any contact. And that led to sudden closure of a lot of services, a lot of situation, without any other avenues being put in place. That, okay, what if this? What if this? And then slowly we started to learn, oh, well, this is the challenge. What can we do about it? How can we do about it? So we went from complete closure to one parent being allowed at the bedside, to two parents being allowed at the bedside, back to one parent, back to two parent. This is all in effort, not anybody trying to see that other people suffer, but everybody is trying to protect other person. Because we were thinking to protect the people who take care of the people, because otherwise we will be all out. I mean, we had instances in the NICU where our team was taken out, like 10 people in the whole taking care of that baby, and suddenly something happens and suspicion happens, and all 10 people have to go home for 14 days, be quarantined, be away from their family. So all this went into equation of trying to find the balance. And I think we are learning more. So as you mentioned, we should be working together more, and we should be putting out. So that's the reason for us doing that paper as well, to give community a kind of a summarized report saying that, look, it is safe. I think we need to continue to work with families and the family organization like yours to support them.
Absolutely. Dr. Shah, thank you. I really appreciate your comments. And obviously, we do understand the stresses and the unknowns that came with the pandemic, and so many unknowns. And now, I mean, I'm very grateful to you because you are very open to work with us parents and give us the voice and share the table so we can improve the journey for the families, the outcomes for the babies. I'm really, really grateful to you and your whole team at Sinai. Any final thoughts how we are looking forward now into the future in this stage that we are right now, slow with the vaccinations, but moving forward? So what do you see in the near future?
Faith, you want to take? Then I will take.
Gosh, that's a really good question. I think, like what Dr. Shah said, we would love to see, going back to where we were, which will be a very long time before we probably get there, but certainly having more families involved in the NICU. Hopefully we can get both parents in rather than just the one. More communication and talking about this, and also addressing the mental health burden that has come with this whole year. for the families as well as healthcare professionals.
Absolutely.
Yeah. I think the other part is that there is a vaccine registry coming out in the Canada. So where we are going to participate in a national study in which we are asking people to participate, especially pregnant women who have received vaccine, to participate in that registry so that we know is there any side effect, is there any adverse events that has been noted, because nobody is going to do a trial of giving vaccine versus not giving vaccine to pregnant women. We are basically have to learn from those who have received and those who have not received and what happens. So what I'll do is I'll say after the talk, I'll send you some link to put it out with the parent in all the organization for any mothers who are interested in participating in this registry so that we learn more. And this similar registries are happening across Canada as well as the world so that we get more and more information. I think that's where we will learn more and we will be able to transmit the information better. And another plea would be if anybody has been vaccinated and are interested, that to join some studies where they can check the antibody levels in either mothers or babies, or do the saliva testing to see what happens to the babies and things like that, by which we can get more information.
Okay, Dr. Shah, Dr. Zhu, thank you so much for joining us here today. I will definitely bring you back to see what is the latest research and the latest recommendations. So thank you.
Thank you very much. Thank you for having us.
Dr. Shah, stay with me. I'm just going to wrap it up and we can talk right after. And thank you everyone for joining us here today from Facebook or YouTube channels, whether you're home or in the hospital. And I also want to thank the International and National Family Integrated Care Committees for their work and for collaborating with CPBF on this talk today. And today's sessions was made possible thanks to our partner, AbbVie. And the video of today's session and all the videos from our live sessions are available on the CPBF website, which is right here, the CanadianPreemies.org. We are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all families. And I'll be back next Friday, 1 p.m. Eastern Time. Stay well, everyone. Thank you.